Welcome to the second William T. Small Jr. keynote lecture. My name is Victor Schoenbach, and I am grateful to the Minority Health Conference Planning Committee for the privilege of presiding over the William T. Small keynote lecture this year. Joining me as co-presider is Lisa Pullen, who will moderate the question and comment period after the lecture. Until his retirement last year, Dean William Small was Associate Dean and Senior Advisor for Multicultural Affairs at the School of Public Health, where he inspired, assisted, and advocated on behalf of thousands of students over nearly 30 years. The trust he earned is illustrated by the fact that even years after graduation, former students seek his advice before making major life decisions. Bill, I wonder if you could stand and let the audience see you as I read the next part. Last year, in preparing some remarks on the occasion of Dean Small's retirement, I telephoned some former students from his early years at the school. Here is the fax that I received from Bobby Primus Cotton. Thank you for the call. I enjoyed the opportunity to relate to old times about old Bill Small. Bill has done so much to create a user-friendly academic environment, that was all uppercase, for the minority student population at the School of Public Health at UNC. His picture should be hung in the vestibule along with other deans like Dr. Greenberg, Dr. John Hatch, and my dear friend Harriet Barr. They believed in the possibilities of the potential minority students, and they believed that the School of Public Health had the potential to make a difference. Please join me in an expression of appreciation for Dean Small. I could go on and on about Dean Small, but we had his retirement celebration last year. This is the time for our keynote lecture, and we are very fortunate to have Dr. Keith Wailoo with us. Dr. Keith A. Wailoo is Professor of History and Professor of Social Medicine at the University of North Carolina at Chapel Hill. He holds degrees from Yale University and the University of Pennsylvania, where he received his doctorate in 1992. His chief interest is the history of American medicine, with emphasis on medical ideas and technologies, and on the cultural, social, and political history of medicine. His first book, Drawing Blood, Technology and Disease Identity in 20th Century America, received an American Public Health Association award. Last year, while spending a year teaching in Harvard University's Departments of History of Science and Afro-American Studies, Dr. Wailoo was one of 10 international recipients of a $1 million James S. McConnell Centennial Fellowship. This fellowship targets 10 early career scientist scholars for work that will contribute substantially to the development of knowledge and its responsible application in the next century. Please join me in welcoming Dr. Keith A. Wailoo.
Thank you, Dr. Schoenbach. Thank you all for inviting me here, particularly the students of the School of Public Health. And I should say that I'm particularly honored to be giving a lecture that has been named in honor of Dr. Dean Small. I'm also honored to be here in the year 2000 as the appointed speaker for reflecting on the past and guiding us. So one of you said, in thinking about the proper frameworks for thinking of minority health issues in the 21st century. Despite the grandeur of the title of my talk, Race, Identity, and the Politics of Public Health in 20th Century America, let me start with a small but important disclaimer, and that is that it's really not possible in the allotted time to tell the story of race, identity, and the politics of public health. And I'm sure if I had the entire day, I couldn't accomplish such a feat. What I'd like to do today is to offer some thoughts on this history from my perspective, based on research that I've been doing and the historical research of many, many others. As Dr. Schoenbach said, I'm a historian by training, interested in issues like the role of technology in 20th century medicine and public health, the transformation of disease, the transformation of race relations in 20th century America and how that informs medicine and public health. And I'm also interested in the ways in which scientific discourses, scientific frameworks, and models of thinking about disease and the technologies that are used in the realm of science inform questions of disease, race, and public health in the 20th century and the relevance of those interactions between science and society for the way we think about disease in the 21st century. So for me, disease as a scholar is a window on society. That's the way a lot of us historians of medicine and science approach the problem of disease. And it seems that to us, in every era, the discourses of the medical sciences and the public health sciences and the transformations of disease themselves can reveal a great deal about social values, cultural attitudes, as well as social and political relations. And that's just a way of saying that that's the framework that I'll be using today in describing this transformation of race, identity, and the politics of public health. I also should admit that I'll be focusing primarily on African American health, and I realize this is a conference devoted to minority health. And so I have to apologize for that parochialism, but also suggest that I believe that the lessons learned from this history are broadly applicable, and perhaps in the question and answer period and throughout the conference we can talk about the broader applicability of the models that I'm portraying here. In today's talk, I'll touch on a few of noteworthy maladies of the century, pausing to examine what public health experts, physicians, and others have had to say about these maladies and what their thoughts reveal about the politics of public health in the time period. I'll be talking about hookworm, tuberculosis, cancer, polio, sickle cell disease, and to some small extent AIDS, but indeed I'd like to leave it for you, those of you who are probably more familiar with AIDS, breast cancer, and other health concerns in the 21st century, to wonder about the applicability of these themes, these historical themes, to the work that you do today. As I said, a lot of what I'll be talking about today is based on the work of many other historians, and I could name them, and that would be a long list indeed. And it's also based on a book that I'm currently completed called Dying in the City of the Blues, a study of race and public health and the politics of disease and healthcare in Memphis, Tennessee, in the Mid-South. And I draw upon that historical work in formulating some of these ideas. And the form that this talk will take, it sort of asks us, what can we learn by scrutinizing the evolution of images of African American health and illness that have appeared throughout the 20th century in American history? I believe you'll be able to draw your own conclusions from these images. And when I speak of the transformation of disease in America, most scholars would think about some fairly commonplace or important but well-known transformations, such as the decline of acute infectious disease, which dominated the early 20th century, the 19th and the early 20th century, particularly among children, and the rise of chronic disease and diseases of the aged. With the aging of population, we've seen a transformation, therefore, in the kinds of diseases that we're talking about in public health and in medicine. In each era, it seems, particular scientific models have prevailed in trying to explain these disorders, shaping the public, and these models have shaped the public health response. So where today fields like genetics provide, it seems, a crucial framework for discussing health, in the early 20th century, the field of bacteriology, one of many, the field of bacteriology was one of many that seemed most crucial to explaining the world of infectious disease and charting society's way through these particular health problems. As for questions of race, perhaps the most crucial question in the early 20th century was the formation of the color line, segregation, particularly in the American South, but throughout the nation. And in what follows, I hope, these seem as if they're incongruous. They have not very little to do with each other, technology, the character of diseases, and race relations. But in what follows, I hope to show how these issues, which seem to be separate, are in fact quite closely interrelated. There were many frameworks used in the early 20th century, for instance, in debating and discussing African American health. Bacteriology would become one of them. But one of the crucial frameworks for understanding African American health in the 19th and into the early 20th century was the labor question. That is, throughout the era of slavery, through Reconstruction, and into the early 20th century, the need to turn out a good crop necessitated among Southern planters a certain degree of attention to black health concerns and black illness. To generalize, you might say that planter paternalism, particularly in the rural South, and planter self-interest, that is the fact that blacks worked for whites and therefore needed to be kept healthy in order to perform that work, established one enduring framework for understanding and discussing race and public health in America. But with the African American movement off of plantations, in a period that's often characterized as, in the early 20th century, as the Great Migration from the rural South into the urban North and into the urban South, new frameworks, new models, new ways of thinking about race and health emerged. As this chart demonstrates, it's from a public health study in the late 1920s, urbanization brought a high price in mortality. And although the trends were generally downward, the disparities remained, and of course they remain today. The highest mortality in this time period among urban Negroes, to use a term from the time period, and then rural blacks, and then urban whites, and finally rural whites. The chart itself, and I'll be talking about these images and charts and ways of mapping health and health disparities, the chart itself revealed the sensitivity of the era to these questions, urban versus rural health, white versus Negro health. But it was bacteriology, one of the high-profile sciences, as high-profile, probably more so than genetics, let's say, for our time period. It was bacteriology that applied to medicine, to diagnostics, and to public health practice in the early 20th century that provided some of the most powerful frameworks for understanding race and health in this new urban context. And throughout public health discourse, the African American, in this case the black woman, was portrayed consistent with the models from bacteriology as a disease vector, him or herself, a conduit for disease, not unlike the mosquito in malaria or in yellow fever. And this image from the 1914 issue of the Atlanta Constitution, and it appears in a book by a colleague of mine, Tara Hunter, a book called To Joy My Freedom, a book really that focuses on black women from the Reconstruction to the early 20th century. This particular image from the Atlanta Constitution makes the point very clearly. The black woman, the domestic worker, took disease and bore it from, which was born, it would seem, from the festering den of contagious disease, took it across rivers of filth, carrying it into the, across the sanitary precautions, the boundaries that were constructed, the screens, the pure water, the sewage, disposal systems, and even the medical sciences, traveling like Mary Poppins from the early 20th century, I suppose, across these boundaries to invade what was labeled here the average white house. And these kinds of images, which pervaded public health discourse in the early 20th century, reinforced the belief that the African Americans and their health was not only a labor issue in this new urban context, after all, she was a domestic worker, but also it was sort of an updated image of this notion of African Americans as laborer and of menace to the white home for these modern urban consumers. These kinds of motifs were repeated from one disease to the next, from one decade to the next, in venereal disease, in tuberculosis, in sickle cell disease, in hookworm, where the leading student of hookworm and the organizer of the Rockefeller Sanitary Commission in the South, Charles Wardell Stiles, theorized in 1911, and he admitted that there was much speculation in these theories. He said, "The Negro has brought hookworm disease with him from Africa, and because of his soil pollution has spread it broadcast throughout the South, thereby killing thousands and causing serious disease among tens of thousands of others." For some, this menace could be used to justify the tightening of the lines of racial interaction, tightening the racial segregation of the time, preventing contact, closely regulating contact perhaps across the color line. He went on to say, we must all frankly face the fact that the Negro, because of his unsanitary habit of polluting the soil, is a menace to others. But others, and it's important to understand that in the context of the time, other voices were thought of as liberal for that era, advocated that what was necessary was not building higher walls to separate the races, but cleaning up the black neighborhoods. Because the reality was that African Americans worked in the households of whites, and for that reason alone, they were important to the economic and as well as the lifestyle of white consumers, and for that reason alone, their health needs needed to be attended to. And so there were liberals who suggested that, well, you know, the answer to this problem is not building higher walls, but actually addressing some of these problems. And this image, also from Tara Hunter's book, really drives that point home. Here you see a portrait in the Atlanta Constitution again of your washerwoman, your butler, your cook, your driver, your clothes hanging on the line, the delivery boy, and their preacher hovering over the contagious disease patient. The image transformed what many might see as a virtue, a kind of collective caretaking of the sick, into a major menace for society. Because it seemed of the role of African Americans in white households, this kind of congregation around the sickbed was a problem. But there's that little bug in the lower right-hand corner, which suggests that the criticism here was not necessarily of African Americans, but what the little bug is saying, he's saying something really needs to be done about this. And there's a little bill on the lower left-hand corner which suggests that it's really because of the lack of hospital facilities that this kind of problem exists. So this is a kind of a liberal call for reform in that time period. The subtle demand for expanding services or for hospital facilities. These kinds of images of African Americans as disease vector, as responsible for bringing hookworm, venereal disease, and other contagious diseases into white homes, really dominated public health and popular discourse in the early 20th century. And I want to suggest that these images built upon the very power of the role of bacteriological models to shape understandings of public health. They seemed obvious because of the importance of bacteriology in this time period. And it seemed important, this is important also because it molded this notion of the bacteriological model being so powerful, molded ideas about race and racial identities. And indeed, in my own work in sickle cell disease, you see this framework being used in the early history of that disease to explain the disorder. In 1917, a researcher in St. Louis discovered a technique that could be used to determine the sickling potential of blood cells in families where sickle cell disease appeared. And based on a rather crude family analysis of inheritance patterns of the sickling potential, not disease, mind you, he speculated that this disease was what was then called a Mendelian dominant trait, which suggested that it could actually spread outward from the black community if racial intermarriage were allowed. And this way of thinking about sickle cell disease, even though we might regard it as fundamentally wrong, an inversion of how sickle cell disease is spread today, it dominated public health and medical thinking about disease well into the 1950s. And it was used as the basis for suggesting not only that intermarriages should be restricted, but also that any finding of evidence of sickle cells using this technique in white people was evidence of racial intermarriage. I mean, it suggests something of the lingering power of this bacteriological model and the notion of diseases spreading outward from the African American community and how those informed public health. Indeed, it would be inappropriate to end any discussion in the early 20th century without pointing, we can focus on the victims and disease vectors, but without talking a little bit about health activism, because African Americans were also health activists in many ways. Whether at the national organizing level in organizing National Negro Health News, or at the local level, black preachers, physicians, midwives, club women, and businessmen embraced the gospel of public health and the public health campaign tailored to their communities. In the age of public health campaigns, National Negro Health campaigns might involve, or propose in this case, year-round activities from child health pageants and parades in May, to hygiene instruction in September, to health discussions in women's clubs, Thanksgiving health sermons by preachers, and Christmas health plays from October through December. And this kind of activism was not without its own politics and its own problems and its own controversies. There were activists, often members of middle-class black communities, who often found themselves coming into conflict with those, quote-unquote, below them in the social order in the black community. In my own work in Memphis, for example, one finds that the organization of the Negro Public Health Nursing Corps in the 1920s was partly a progressive development. After all, who could dispute the need for public health nurses in black communities in communities like Memphis in the 1920s? But if one looks behind the creation of such corps, it becomes clear that those nursing corps were created partly to combat the rising prominence of black midwives in Memphis communities. And in fact, as one university obstetrician noted, quote, "The practice of public health is to control the work of the older midwives and to restrict the number of new permits issued to younger women." The Black Public Health Nursing Corps was used to educate the midwives, to inspect their bags, but ultimately to help push them and force them out of the city. Another sign of conflict, when the black minister Tio Fuller in Memphis decided to embrace the gospel of public health in the 1920s and 30s, he also found himself coming into conflict at odds with his own congregation over the gospel of ventilation, sanitation, and particularly over the question of whether the congregation should be encouraged to use individual communion cups rather than communal communion cups in the name of public health. And he bemoaned the fact that, he said, unfortunately, Negroes have the idea that when at church, the laws of health are suspended. So it would be a mistake for us to see the conflicts in the politics of public health only as a politics between black and white communities. There's also an important politics to pay attention to within the black community itself, which often plays itself out in terms of these sort of class relations. As many in his congregation believed, his ideas of individual cups was a sign of his actual lack of faith. The idea of individuality in taking communion seemed to undermine their sense of faith and their sense of communality, which of course was the central strength of the black church. These are but two examples of the kinds of tensions that emerged within the African American community over public health in the early 20th century. In the midst of all of this activism, the stereotyping and discussion of blacks as disease vectors, public health academics and field workers continued to map the contours of race and health in this time period, and these are just some examples. They noted, for instance, the rising incidence and the lingering disparities in areas like cancer, a problem discussed again and again throughout most of the century, and it continues to be an important one today. Most recently, this unequal burden of cancer was discussed, I guess, in an IOM, National Institute of Medicine report just last year. And they also focused on the lingering disparities in infant mortality. And this report on Memphis in 1930 through 1932 was issued in the wake of an embarrassing U.S. Public Health Service report, which highlighted that Memphis, this city, which was aspiring to greatness in the early 20th century, had, in fact, the highest infant mortality rate of any city its size in the nation. Evoking once again the image of the disease vector almost as a defense of the city's good image, the city's public health superintendent insisted, quote, "Because Memphis has a large Negro population, and because it is a medical center for a large area in the tri-state, that is, it neighbors Arkansas and Mississippi, the very poor rural counties of Arkansas and Mississippi, its infant mortality rate is necessarily higher." It seems strange to hear a public health official saying that, but it's necessarily higher. And he goes on to say, quote, "Babies die in Memphis who were not born here and whose parents do not live here. They were never in Memphis until they were brought here in a dying condition. Once again, a kind of a strange, attitude. And the obstetricians defended this point of view and regarded this U.S. Public Health Service report as a kind of an effort to embarrass, a blemish on the city's record. The research on Memphis I've done highlights the pervasiveness of this framework, this notion of disease vectors, carriers, people coming from elsewhere, visiting disaster, menacing the city. And it's important to understand the centrality, therefore, of this image of the carrier for all discussions of race, public health, and the guiding of public policy in the early 20th century. The images of race and health were those of sunlight and shadows, and this is from a cover relief of a 1951 book on plantation healthcare. At the front door, you see a buggy in the sunlight with a white physician. The back door, in the moonlight, the black midwife. There's a dense forest in the background. Dark figures, I don't know if you can see them very clearly, engaging in some strange rituals on the far right. This is still sort of the image that's dominating medical discussions and public health discussions into the 1950s. And this is the prevailing image, 40s and 50s in medicine and public health. But a new era of science seemed to be emerging around World War II and in the wake of World War II. And what I'd like to do is shift our frame of reference for a moment and talk about these new models that are emerging in this time period. New sciences seem to be emerging in the wake of wartime achievements in the production of penicillin, in the development of chemotherapeutic agents for the treatment of cancers, and in post-war description, the post-war description of the structure of DNA. And this would inaugurate a new era of faith in science and technology, but a new era in which molecular biology promised to revolutionize ideas about disease, health, and public health practice. In the wake of the gradual decline of childhood infectious disease, maladies like diphtheria, for instance, no longer seemed as crucial in public health discussions, whereas maladies like polio, which would have been around since the 1910s, seemed all the more important now because they were anomalous indicators of the lingering nature, right, the lingering presence of infant mortality. And the eyes of Americans turned not to public health practitioners so much as virologists like Jonas Salk in the biomedical sciences to create the new tools of public health management through vaccines, created out of the development of virology in the 1940s and 1950s. At the same time, this was an era in which the color line came under attack. The first significant conflicts over segregation emerging in the 1940s and then 1950s. Again, these might seem like disparate events, but as before, I'd like to try to suggest how these issues informed one another. Let me confine my remarks, since the story gets more and more complicated, I think, the closer and closer we get to the present, especially as a historian, because the more and more your audience actually knows about the history, the less easy it becomes to kind of just make some generalizations. So you have to kind of focus in a bit more. Let me confine my remarks to three sorts of themes then. One is, what do we make of these new technologies of diagnosis and the invention of sort of a modern idea of the disease carrier? I want to talk a little bit about what the modern idea of a disease carrier is. Secondly, I want to focus on the ways in which new therapeutic innovations, whether penicillin, but in this case, things like blood plasma transfusion, could be used to highlight and dramatize the unfairness of segregation and suggest reforms in public health and medical practice. And thirdly, I want to look at how new diseases, like polio, for instance, new in the sense of, new and high profile, seemingly anomalous, standing out against a changed backdrop, how these new diseases could inspire new discussions about race and public health in the 1940s and 1950s. The post-World War II era of molecular biology saw the incorporation of many new tools into the armamentarium of medical sciences and public health practice. One of them was a tool that was created in the 1930s, electrophoresis, making molecular anomalies in the hemoglobin, for example, visible on a molecular level. and therefore making more visible diseases like sickle cell disease, which had their origins in these molecular abnormalities. These are diseases like sickle cell disease, diabetes, cystic fibrosis that had been kind of shrouded, veiled by the heavy pall of infant death from infectious disease in the early 20th century. And with the decline of infectious disease and the emergence of penicillin and the ability to treat those infections, it's as if these diseases were really appearing for the first time in the post-World War II era, visible in a clinical sense, but also visible because of the incorporation of these sorts of diagnostic tools into medical and public health practice. So penicillin was a sort of a key part of this new visibility of disease. Electrophoresis would also usher in, however, a kind of a re-ushering, you might say, an old conception of the disease carrier, which dated really back to the early 20th century, not the carrier as a carrier of microbes, right, and microorganisms, but a carrier in the sense of a hereditary carrier. And this is sort of an updated image of the carrier that emerges in the 1940s and 50s. For in this era, it became clear from the use of electrophoresis that one need not wait until a child was born with cystic fibrosis or sickle cell disease to be able to identify the carrier, the parent, the carrier or the heterozygote, the person with these recessive traits, who, if they married someone else with those recessive traits, ultimately might, there's a 25% chance, might produce a child with the disease. Electrophoresis, and of course our own embrace of genetic testing today, brought this carrier into full view as a modern public health problem. And some of my interest has revolved around the theories that are generated about these carriers and these different disorders, sickle cell disease among African Americans, Tay-Sachs among Ashkenazi Jews, and cystic fibrosis in Caucasian Americans. And I won't go into detail, but I'll just mention that, you know, there are these images, therefore, that emerge about questions that emerge over why the heterozygote has prospered as they have through human history. What are their origins in Africa? Do they have a special selective advantage for surviving in areas where there's falciparum malaria? And these are the new discussions about race and the carrier and the heterozygote that are emerging in the 1950s, really out of theorizing and speculation in molecular biology and evolutionary biology, informing Americans' sort of modern ideas about what it means to be African American. And there are other technologies that emerge and become the basis for discussions about race in the World War II era as well, also raising fears and concerns about race and inequality and the logic or illogic of Jim Crow as an institution. In this cartoon, which appeared in a 1942 New York Black newspaper, amidst controversy over the American Red Cross and the U.S. military's practice of blood segregation for the purposes of transfusion, one cartoonist editorialized the following. It's labeled An American Tragedy. In the first caption, a white soldier, and here you see an interesting twist where the victim of the system of segregation is not the black soldier, but the white soldier. The white soldier, bleeding from his war wounds, crawls up to a Red Cross van, and the Red Cross attendant says, "You might as well wait here, bud. We ain't got nothing but Negro blood left." The next caption shows a scientist scratching his head because the labels have fallen off the bottles. And he scratches his head and he said, "What a dilemma. The labels have come off. Now how can we tell the white from the Negro plasma?" And of course, you know, blood plasma transfusion is a sort of a product of the World War II era. And the poor soldier in the back says, "Hey, Doc, so what? I ain't ranking." He doesn't really care. The next slide shows kind of a group shot, really, at the system at work, you might say. The white soldiers looking at the Red Cross Blood Transfusion Center and saying, "Geez, looks like the colored lads is the only one who's got a round-trip ticket at the hospital today." I don't know what kind of accent that is. And then the other guy says, "Guess they only got Negro blood. We got to wait if we can last." And finally, the last caption shows a kind of heroic, you know, selfless image of the black soldier and his white physician. And he turns to the physician and he says, "Listen, Doc, if I need a transfusion, give me anybody's blood, so long as I can get back to the front. And it's these sorts of images of kind of black sacrifice on the front and the sort of illogic of the blood transfusion system that sort of propelled African American politics and the politics of race and health into the post-war period, into the 1950s. The controversy here was one of many that set the stage for rethinking race and public health after the war. Here, at least, and one finds many of these images and arguments elsewhere, it was the whites who were the victims of a system without basis in modern science. It's useful to reflect on the differences and similarities. I know some of you will be discussing organ transplantation, organ donation, and racial controversies in the 1990s and the year 2000. And it's useful to reflect on the differences and similarities with this sort of image of blood transfusion in the World War II period. The focus on polio as a new, and I use that in quotes again, public health dilemma would also refocus attention on the color line, race relations, and ideals of inequality. As one author in a Memphis newspaper, William Gordon, wrote in the newspaper in 1940s, polio knows no color line. And he pointed to the democratic practices of the National Foundation for Infantile Paralysis and urged their democratic practices and their treatment of patients without regard, to race, creed, or color as a model for the future. For, as he said, people are beginning to establish the realization that we all have feelings and an appreciation for a healthy way of life, and that in order to achieve this appreciation, we must work together. Others, however, would emphasize, quite to the contrary, that there was a color line in polio. As S.L. Wadley of the Memphis Public Health Department noted, the Negro attack rate has been consistently lower than for whites, but no one has offered a valid explanation of the significance. Indeed, he suggested that, ironically and paradoxically it would seem, poor sanitation, hygiene, and housing actually protected blacks from polio. He goes on to say, the theory has been advanced that Negroes living in less favorable sanitary surroundings and in more overcrowded housing acquire the disease at an earlier age when it manifests as a subclinical infection that is not recognized. And indeed, many historians and many believe that polio became epidemic, that this is an accurate model to understand the incidence of polio. That polio, in fact, became epidemic really in large measure in the early 20th century, ironically and paradoxically because of improvements in sanitation, hygiene, and public health. The very fact that children did not become exposed to polio at infancy, at which point it really does manifest itself as a mild fever, as a subclinical infection, made it so that by the time they became exposed to polio at the age of 7 or 8, it had serious paralytic and obviously mortality consequences for mortality. So this model of thinking about polio was not altogether sort of out of the realm of clear thinking. And one way to think about vaccination and the Salk vaccine and the Sabin vaccine of the 1950s is to understand it, and this is how I talk about it with students, to understand it as an effort to make the biomedical sciences do what nature, that is the dirty, filthy, slummy conditions of 19th century urban society, did quite naturally, which is to immunize children against polio. And that's quite a feat to actually mirror nature. The focus on the new carrier of disease, the problem of blood transfusion, and the case of polio suggests something about how new technologies, new diseases, and changing race relations were unsettling old assumptions about race, health, and identity. Now, let me condense my thoughts on the succeeding 4 decades, the 60s, 70s, 80s, and 90s, and this is quite an undertaking, by focusing on one case. As I explore in the study that I've described in Memphis, it is in the wake of these sorts of developments, molecular biology and its new framework of thinking, diagnostics, therapeutics, race relations changing, and society at large, that new diseases emerged from obscurity and created disease identities in which began to form and really take kind of public form in the post-war era. Patients' experiences take shape and are articulated, as you see here. In the context of the struggle for civil rights, patients' rights, for example, the focus on sickle cell disease seems particularly poignant, whereas in the early 20th century, public health practitioners, physicians, and community members thought that tuberculosis or syphilis was the best sort of model for thinking about race and health. Well, in the 1960s and 70s, sickle cell disease comes to occupy that space for public health practitioners and others. And it's partly because, not just because of the rising prevalence or the ability to see the disease more clearly, it's also because of how the disease evokes the question, or evokes the problem of African American life and existence in America. The common phrase that was used to describe sickle cell disease is a disease of pain and suffering that has long been ignored, which of course reflected and sort of evoked and resonated with civil rights language from the 60s and 70s, the idea that finally historical injustices, right, blindnesses, invisibilities in American society were being seen and for the first time addressed. Here was an experience that was emerging characterized by frequent, recurrent, painful episodes, coming to be a poignant example, it seemed, of the African American condition. For it highlighted and testified to, as many authors have pointed out, the pain and suffering of African Americans. It's spoken of in the 1960s and 70s as a neglected disease and comes in many ways to be a proxy, you might say, for the African American condition, but not an image that is generated by the public health practitioners' fear of the Negro menace, but it comes out of the experience of African Americans themselves. The focus on this disease comes out of a focus on the African American experience itself. As this disorder becomes more visible, so too did other problems, however. I don't want to suggest that this is a kind of a wonderful story. Blind spots, you might say, in the history of public health. At the same time this disease emerges into public visibility, other problems in public health emerge, such as the U.S. public health experiment on untreated syphilis among black men in Macon County, Alabama, the Tuskegee syphilis study. And here we have a striking difference in the portrayal of race and public health in the Atlanta Constitution, once again, almost 60 years after its 1914 picture of the black female domestic worker flying into the average white house. For here, the doors swing open on the history of neglect, and the focus turns to the practitioner with his victims in the background. And this revelation did not so much signal a shift in public health as one of many controversies in the years 1970, 71, and 72 around the question of race, science, and the politics of health. There was, of course, the infamous IQ controversy, in which Shockley and Jensen argued in an attack on the Great Society program and the ideals of the Great Society that it was possible to actually restore equality through social programs. They argued that IQ, which was for them an index of racial disparities, racial disparities in IQ were explained by inheritance, and therefore we weren't doing very much to try to resolve these problems through education. That was their argument. And even as the formerly invisible disease, sickle cell disease, became more visible, there were, of course, controversies which we're all familiar with. Controversies over mandatory screening practices, what to tell the carrier about the likelihood of their having children with sickle cell disease, how coercive or directive should screening practices be, should it be mandatory or voluntary. It did not help matters as these controversies swirled that, for example, Linus Pauling, the discoverer of the link between hemoglobin and sickling in the 1940s and 50s, noted in the pages of the UCLA Law Review that, quote, we should put a tattoo on the forehead of carriers so that they would recognize each other in life, early in life, and avoid falling in love with each other. In the wake of these kinds of comments and an effort to explore the question what to do about these modern carriers, in the wake of controversies over directive genetic counseling, over IQ, over Tuskegee's revelations, the issue of disease screening became highly contentious and controversial. The U.S. Air Force in 1971 had instituted a ban on people with sickle cell trait, carriers, heterozygotes, whatever term you'd like to use, which was because of fear that at high altitudes they would actually fall into the same crisis that frequently affected people with sickle cell disease. And that ban was lifted in the 1980s and remains actually still controversial. In my research, I've examined how the focus on the carrier grew, shifting attention away from the patient in the 1970s. And I think this is really important. As the focus on the controversy surrounding what to say to the carrier emerges, this notion of, sickle cell disease as being a unique and important, authentic African American experience that warranted therapy, that warranted attention, really was pushed into the background. And of course, all that the disease experience was supposed to exemplify about the history of race and health was also pushed into the background. In the intervening years, other forces have kind of shaped how we think about sickle cell disease, with a focus, for instance, on the authentic African American patient experience of the disease in the 1960s. From that, there emerged a focus on pain management. Of course, once you highlight the importance of the painful experience, what follows is the importance of pain management. But this, too, has been altered in recent decades and became very quickly the focus of controversy, as a tendency has emerged, particularly in the last 10 or 15 years, to regard urban people with sickle cell disease as just really another variation, another feature of the inner city drug problem. I mean, there's a tendency in lots of clinics, emergency rooms, to look at sicklers, people who are looking for relief from pain, which often involves treatment with narcotics, as a variation on the urban drug problem. And as one author has noted, and many others have pointed out, this is an article from Discover magazine, November 1993, for the sickler, before you can get past the agony, you have to get a doctor to believe it's real. And this is a story about a woman in New York City with sickle cell disease and the problems that she has gaining relief for her recurrent pain. Now, of course, this is part of a much more general problem in the 1990s and the year 2000, a problem of the disparities in things like pain medication. A colleague of mine in the School of Public Health, Jay Kaufman, recently sent me a reference to another controversy around analgesics, ethnicity, and the treatment of long bone fractures that I believe appeared in Emergency Medicine just earlier this year. So what I want to suggest is, even though these diseases have, like sickle cell, have emerged in visibility, and that we have an atmosphere in which we pay more attention to the patient experience and seem not to engage in the kind of stereotyping and metaphorical thinking about disease carriers and vectors that seem to dominate the early 20th century in public health and medicine, that these sorts of models and frameworks linger, and they continue to inform public health practice and medical thinking at all various levels, with obvious implications for the treatment and relief of pain of minorities. What then can we conclude and learn from scrutinizing the evolution of these images? The evolution of these images and controversies in race, identity, and public health in America. Well, I'd like to leave you with just really 3 points. One, I hope from this talk you gain a sense just really of the narrative, or at least my construction of the narrative of race and health and the politics of public health in the 20th century. Secondly, I hope you understand, and this is a truism by this point, but I think it bears repeating, that disease and health are far more than biopathological frameworks or models of thinking, but profoundly embedded, disease itself, profoundly embedded in society, politics, and cultural concerns, changing always with the context of the times. Third, I'd like to suggest that the very tools, models, conceptual frameworks that we use, whether they come from bacteriology and infectious disease, molecular biology or evolutionary biology, or statistics, have enormous significance for shaping the cultural meanings of disease, and that our use and interpretation of those tools are also shaped by culture, context, whether we acknowledge it or not. And as a practitioner in history, I'm always aware of that, and I think among public health practitioners and medical practitioners, it behooves us to take a certain distance and reflection on the very tools that we use, the inadequacies of those tools, and the messages that are sent by promoting those tools as the true and only ways of understanding disease. And finally, I said 3 points, but let me throw in the fourth one, which, as the story of the carrier suggests, science might change. Science changes from one time period to the next, models of disease change dramatically from one time period to the next. But I want to leave it open to you as you go through this conference to what extent these themes and these issues continue to linger, just as the carrier, despite the transformation of science, sort of lingers as a problem and as controversy within public health and medicine today. And I'll leave you with that. Thank you very much for your attention.
Thank you, Dr. Wailoo, for that thought-provoking address. Now we would like to entertain questions from the audience. There are two mics. If you could go to the mic down here or either over here.
Hello. Go ahead. I wanted to ask specifically about your methods for doing the research. Is it common to use political cartoons, or is that something you did to give us the point easily?
Increasingly in the practice of history, it is common to use political cartoons and these sort of images from American culture. For many, many decades, it was considered to be kind of crass and not really doing real history to do so. But I think increasingly newspapers and these sorts of images are integrated into historical analysis because, of course, these are the images that are communicated very broadly, right? I mean, it's one thing to say that, the history of science moved along a particular framework and to study history of science from the standpoint of the disciplines. And it's another thing to talk about how those models that are used in those disciplines generate broader images of race and health or patient identity. And so I wouldn't say that it's common to use them now, but it's a growing trend in history and in the history of science and medicine.
Thanks.